Hello, and again, thank you very much for inviting me to speak today. It's great. So I'm Iain Davidson, I'm the Chief Pharmacist and CCIO at the Royal Cornwall Hospital, and we are one of the demonstrator sites. So let me move on. So, it's not an ambulance car park, that is the Royal Cornwall Hospital, and we are the only acute trust in Cornwall. We've got about 750 beds. We're based across 3 sites, the main one being in Truro, and we have a turnover of about £320 million. From a pharmacy department point of view, it's about 110 whole-time equivalents. We dispense around 40,000 items a month. We've had electronic prescribing in for 3.5 years now, and we administer 250,000 doses of medicines to our patients each month, which is always an interesting figure I hold in my head. And we spend around £30 million a year on drugs. So before I plough into the whole GS1 thing, just a bit of background and some context around medicines and pharmacy in the NHS. So, hospital sector, last year we spent £6.7 billion of our money on medicines in hospital, and that's going at 15% a year. The 10 years between 2003 2013, the average number of prescription items per person in England went up from 13 to 19 per person. So we have a massive sort of cost pressure here with medicines. 5 to 8% of patients that turn up to our ED department are there because of medication issues, so we are causing big patient safety problems with medicines. And the King's Fund reckon that we throw around £300 million worth of drugs in the bin each year. Around half of that, £150 million, is avoidable. The Lord Carter review that was published recently has done a quick tot-up of all the acute pharmacy stock holdings and reckons there's £200 million sitting on our shelves in our pharmacy departments. And if we could all get that down to a maximum of 15 days worth of turnover within our pharmacies, that would be a one-off saving to the NHS of £50 million. And then beautifully as well, the Lord Carter, for any Director of Finance and Chief Execs in the room, also states that for every £1 invested in clinical pharmacy service in a hospital will deliver a £5 return on investment, which is obviously music to my ears. And clinical pharmacy is where you've got pharmacists, pharmacy technicians, the pharmacy team working on the wards with patients, talking to patients about their medicines, helping clinicians prescribe, helping nurses administer, all that kind of stuff, and it's really important. The dynamic at the moment and the challenge that Lord Carter throws down to us is that 55% of a pharmacy team's time is spent on what's called the infrastructure services, so supplying medicines, procurement, contracting, dealing with drug recalls, patient safety incidents, all that kind of stuff. And we need to change that. The challenge is 80% of a pharmacy team's time needs to be spent on direct patient care at the side of the patient's bed. So that kind of puts it in context, and I think you can see from that actually GS1 has got a lot to offer us in medicines and within hospital pharmacy. And the 3 main objectives for me, and I think it's been very much echoed in previous talks around GS1 adoption in healthcare, is around improving patient safety, releasing time to care, and improving efficiency. Now, I'm not going to go through this slide in any particular detail. I'm very grateful for Judy Fine-Silver from the CMU for giving this one to me, but this is a slide that basically sets out all the IT that sits medicines-related IT in a hospital and all the interfaces to primary care. And the key message is it's a very complicated world out there. There's all sorts of interfaces, all sorts of things, and data needs to flow around that. And for data to flow around that, we need to have common standards. And that is where absolutely GS1 comes in when it comes to medicines, if we want to have a really good comprehensive electronic record by 2020. Trying to narrow it down a little bit to the process within a hospital, and again we're talking around a model hospital, moving towards a model hospital with Lord Carter and that kind of setup. So what I'm about to describe is by no means ubiquitous, but is probably where we are moving. So the pink squares is kind of the patient journey. Patient gets admitted. Most hospitals either have or are about to go live with electronic prescribing and administration of medicines. So medicines are prescribed electronically. The patient gets administered electronically and then gets sent home with a lovely electronic discharge that gets pinged straight off to the GP and elsewhere. From a drug point of view, the flow around that, we buy our stuff from the wholesaler. We've all got electronic stock control systems. Nearly every acute trust in the country has a robot that dispenses the medicines for them. And we're getting more and more now, up at ward level, we're getting electronic drug cabinets, and then the medicine moves in and is administered to the patient. So that's great, isn't that great? And the key point from that is there's IT pretty much at every step of that stage. The trouble is it just doesn't talk to each other, so we don't have data that flows around the system. We've got rudimentary links So you want to book out of some paracetamol, that comes out the robot fine, but actually getting that data around, so yesterday's thing from dockside to bedside, we don't have that information. We can't have that at the moment. So that's the real challenge for us. But because we've got IT at every single stage there, you can start to drop GS1 standards into it relatively simply, really, and that can then start to add real value. So you've got your GTINs with your drug identifier, you've got your GLNs with your location, you've got your GSRNs, which is your nurse, your patient, your pharmacist, your doctor, whoever it might be giving care. And you can start to pull all of that together and really do some very powerful stuff with the data. Our learning from the EPMA deployment over 3 years has been partly around the safety that electronic prescribing's brought us, but about the amazing stuff we can do with the data that comes out at the end of that as well. So adopting GS1 standards kind of has to be a two-phase approach for us. So one of them is actually, do you even have a repository in your IT system for GS1 stuff? Because if you don't, we're going to struggle here. And then the second thing is, once we've got those unique identifiers in those systems, we can start building those bridges around the different systems, and the data can start to flow. So that is really what we are sort of looking to try and achieve some of that as demonstrator sites. And the thing is, we've got all the gear. It's great. I've got a lovely stock control system. I replaced my robot last year. We've got one of those. I've even put some labelers on it. We're getting some electronic drug cabinets in. We've got electronic prescribing in. Absolutely fantastic. And in my utopian world, a doctor prescribes a medicine. The pharmacist says, yes, that's safe, and that's it. It comes out the robot with a label on it, goes up to the ward, goes into the electronic drug cabinet, administered to the patients, tracked straight there. We know exactly who's done that. It then orders another pack out of my robot downstairs when that's running a bit low and places an order with our wholesaler. All absolutely perfectly achievable, all being done in different pockets around the NHS. So we know it can be done, but we need GS1 standards in there. So then it doesn't matter which robot you've got, it doesn't matter which stock control system you've got, we've got those unique identifiers that can flow around the system. And why is it important to do it now? So this is a slide I nicked from a chap called Bob Watchner that's doing a big digital review for Jeremy Hunt at the moment. And he did a seminar a couple of weeks ago. And this is looking at the uptake of electronic health records in the US off the back of the meaningful use data, the meaningful use fund, sorry. And you can see they've had a lovely exponential increase in the uptake of EHR over there. The problem is, as Bob says, they didn't sort out their interoperability, they didn't sort out their standards before they started this, so now they're having to unpick an awful lot of this. So if we can get this right now, before we hit that real exponential increase as we move to a digital record by 2020, then it can only be a good thing. Okay. So there are some absolutely fantastic examples of stuff going on out there in the country, and some of them are very simple, some of them not so, but I'm just going to rattle through three quite quickly. One of them is so simple, we even managed to do it at the Royal Cornwall. So this is Scan for Safety at the Royal Cornwall Hospital, and this is something called a transcription sheet. So for any of you that work on wards in hospitals, you'll know transcription sheets. So a nurse needs a drug for a patient. It's not stocked on their ward, so they write it on a piece of paper and say that we need this from a patient. The pharmacist strolls up to the ward, says, yes, that's great, perfectly safe, and then that gets sent down to the dispensary and dispensed. That was the good old days. As we've moved to electronic prescribing now, we have this very nice electronic transcription sheet that prints off every 15 minutes down the dispensary. The old handwritten thing was strewn with all sorts of errors, handwriting errors, requests going missing, causing real patient harm. So now we have these things printing out every 15 minutes down the dispensary. We know exactly what we're doing. And we thought, well, why not put in a bit of barcoding into this? So we started to drop the barcodes in. They're not all quite GS1 compliant yet, but we're close to it. So we've got the GSRN for the patient name, we've got the location with a GLN there, and then we've got the GTIN for the drug identifier. So rather than having manual entry down the dispensary, it's just a quick zap, zap, zap with a barcode, and away we go. So much quicker and much safer. And what we've managed to do is basically halve our dispensing error rate. So we've gone from about an error rate of 1 in 10,000 down to 1 in 20,000. And we've also improved our throughput, so we're much more efficient. So previous to this, less than a quarter of our workload was done by 10:30 in the morning. Now over a third of our workload is done by 10:30 in the morning. And the impact of that on patients, is we've seen a massive reduction in the amount of missed doses of critical medicines due to medication unavailability. So we're getting medicines to patients quicker, and this is your Parkinson's medicines, your anti-epileptics, the really important stuff that you don't want patients to miss a single dose of, and we've managed to halve the rate of that off the back of this. So that's an example from Cornwall. We've got Rob Beard at Sunderland. He's doing a couple of sessions here. He did one yesterday and he's doing another one today, so I would encourage you to go along. But he's sort of got half of my utopian world in the Sunderland. He's linked his electronic prescribing to his robotic dispensing. So doctor prescribes, and it comes out of his robot with a lovely label on, which is fantastic. And the graph there at the bottom, he put that in about 2010. He doesn't have dispensing errors anymore. Forget the 1 in 20,000, he just doesn't have dispensing errors. So that has got to be better for patient safety. It's got to be a more efficient process. And has it achieved the sort of objectives that we're looking for GS1 to achieve? Well, yes, it has. He's been able to release staff, redeploy them. He's been able to have much more efficient stock holding. It's a much safer process, and it's a much more efficient process. So well done to Sunderland for that. Isle of Wight, Jill Honeywell's the chief pharmacist up there, and she's managed to link her electronic prescribing system with the electronic drug cabinets and with their robot downstairs. So basically, a doctor prescribes paracetamol for Mrs. Smith. The nurse goes to electronic drug cabinets and says, oh yes, Mrs. Smith needs a paracetamol, administers that dose to the patient, so that tracks the medicine to the patient, but the electronic drug cabinet knows actually we're running a bit low on paracetamol, I needed to order that from my robot down the dispensary, and that happens automatically. So again, trying to link all these things up with standards, and have they achieved the sort of objectives that we need? Yes, 11% reduction in drug ward spend, 83% reduction in missed doses for patients, reduced lengths of stay for patients, freeing up nursing time care, etc., 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 delivering all the stuff that we know adopting standards like GS1 can do. So absolutely, obviously, GS1 can deliver what we need it to within medicines. The sort of role of the demonstrator sites, as I see it, is trying to make that scalable and make that so it's not just little pockets around the country that are doing this, but actually all the things that we buy, all the IT systems that we buy, have these standards in there, so that actually this kind of stuff is just what happens when you put your new robot in, when you put your electronic prescribing in. So that's great. Obviously, we need to do a few things to help with that. So this is just a graph of, or a graphic from the NHS benchmarking data from last year around pharmacy stock control systems that are out there. And you can see pretty much 90% of all acute trusts have either JAC or Ascribe. So if we want to do something with GS1, they are obviously pretty key players. Our suppliers and working with them is pretty key. Robot-wise, electronic drug cabinets-wise, whatever it is, there's 2 or 3 players generally in the market with these things, and we need to make sure that they're really engaged and really on board with GS1. We had quite a lot of discussion yesterday about the wonderful Falsified Medicines Directive that's coming our way by 2019 and all the sort of regulation that comes with that. And there are a number of unique identifiers out there, and we need to see how all those are going to fit together. So at the sort of product level, you've got the Dictionary for Medicines and Devices. You've then got the GTIN, which is your sort of product, supplier and batch number. And then you've got your Falsified Medicines Directive, which is actually the box of paracetamol in your hand. And we need to understand how all that's going to fit together. And obviously our suppliers need to understand that as well before they start to develop stuff. And you saw this from the ABPI again, but this is just the timelines for these sorts of initiatives. So we've had the e-procurement strategy, we've had the Lord Carter stuff, really clear message there to chief pharmacists of what's expected. Basically, the Lord Carter for chief pharmacists is the 5-year plan for hospital pharmacy. And we're at that very business end now of actually trying to implement these standards and start to move to a more clinically focused and patient-centred service. And the last thing we need to do is make sure that we're working in a coordinated and collaborative fashion. So some of the comments yesterday around, we're certainly not in competition at all. We had our first sort of conference call with all the demonstrator sites, all the pharmacy departments last week, just trying to get an idea for what our critical success factors are, trying to come up with our key performance indicators, that kind of stuff, so that we can start to go to our suppliers with a coherent message of actually this is what we really need you to do, this is where we think we can get some real benefits, what can you do, how can we work together, and obviously the Department of Health and GS1 have a big role in that as well. And that is pretty much me. So thank you.